general osteology and arthrology. What I'm going to talk about is about the bones first, a very brief summary of the classification of the bones and the structure of the bones, very briefly, and then I will talk longer about the joints, what kind of joints we have. I will talk about continuous bony connections, and I will talk about discontinuous bony connections with several groups and subgroups, and I will classify them according to the number of axes. So let's start because it's a lot. First of all, the bones. Of course, everyone knows that the human body has a skeleton and it has parts. I don't think so. I have to introduce the head, the trunk, and the extremities, where we have the appendicular skeleton. In this semester, you will learn a lot about the skeleton. You will learn almost all the bones of the human body. But if I have to give a general introduction, I have to tell some functions also. I think it's obvious that it forms the framework of the body, which gives a certain support for all the structures. I also don't surprise you with that. I think that it is part of the locomotor system, because if you move, if you run, if you jump, your muscles carry out the movement, but we move because our skeleton is moving, and this is how the body is then moving. So the locomotor system together with the bones and the muscles together will carry out the movement. Also, it is a strong system of tissues. It may provide protection for the internal organs. There are several quite sensitive organs. The brain is inside the skull, the spinal cord is inside the spine. Also, the thoracic organs, the heart and the lungs are covered by the skeleton. So this is also something that is essential to provide the protection. And also, you have to know that the bone tissue has cavities inside where we have bone marrow tissue. And in the red part, the red type of the bone marrow, the blood production takes place. In the histology classes. You will talk about the blood production later. And biochemically, the bone is a huge storage for calcium and phosphate ions, which is required for several biological functions, and therefore the skeleton is also important in this view. Okay, if we turn to the anatomy, one can classify the bones into several subgroups, and there are many different classifications. This one I would prefer because it's quite simple. We have the long bones or the tubular bones, and we have the cuboid bones, which have more cube shaped, shorter bones. We have also plain bones you will study soon. The scapula must be already familiar to you. And also we have so-called pneumatic or pneumatized bones, which have cavities inside. And an example for that could be the facial skeleton. You have several bones in the visceral cranium in the face, where the which are filled by air, and this will be also very important for the functions. Okay, so these are the types of the bones. If we go on to the next slide, then this is what I wanted to tell you about the classification of the bones. And now let's talk a bit about the structure of the bones in general. On the example of the humerus of the arm bone, let's tell me some basics. So if we cut the humerus longitudinally, you will see it's a long bone, of course, and you have a mid part of the bone that is called diaphysis most of the times. It's a Greek term, and the bone has an end part. Actually, it has two end parts. It has an epiphysis on the top, and it has an epiphysis at the bottom. You have therefore the proximal and the distal epiphysis of the bone. This is these directions are already familiar to you from the classes of the last week. Then at the border of the diaphysis and the epiphyseal part of the bone, you have the so-called metaphysis. Here is the bone getting wider, and there is a sharp line here inside the bone. This is the epiphyseal line. I will come back to this structure in a later slide of mine. I will explain you what's this. And also please note that the bone has different structures at the end, at the mid part. So at the end of the bone, you have a spongy substance inside where you can find red bone marrow tissue in the small cavities. And in the middle part of the bone, you have a compact structure outside, that's compact bone. And in the center of the bone, you have a wider cavity that is the medullary cavity, filled by yellow bone marrow tissue. It's basically fatty tissue, and most of the times in the body of the bone, in the diaphyseal part, one can find a blood vessel also that enters the bone and provides the blood supply. Also good to know that the surface of the bone is covered by a layer of connective tissue that is called periosteum. And the periosteum is very important in the clinical practice because this is the source of the regeneration. So if the bone breaks after a fracture, the healing process starts with periosteal reactions, and a quite complex process is starting, but the periosteum is involved in that. In the cavity of the bone, in the bone marrow cavity, you have a similar connective tissue lining that one may call endosteum as well. Okay, so these are the general structures of the bone, and I will talk about the joints a bit later, but maybe I mentioned already now that most of the times at the ends of the long bones, you have surfaces which will contribute to the joints, and they carry articular cartilage because they form the articulating surfaces of the bones, but this will be discussed in a later slide of mine today. So this is the a slide about the compact bone and the spongy bone. Two examples you have here. On the top, we have the cross section of a vertebra, and in this vertebra you have a spongy bone. And on the bottom picture, you can see the long section of the head and neck of the femur, where you can see both spongy bone, and in the upper part of the body of the bone, you can still recognize compact bone also. So what I want to demonstrate with this, that the spongy bone has a quite complex structure. Inside, you have a meshwork of bony trabeculae, which are very strong at the end, but they form a kind of spongy structure in which you have many smaller cavities. And in that, you have bone marrow tissue, red bone marrow. The same applies for the head of the femur and the neck. But then the compact bone has a different structure, and this will be discussed in detail in your histology lectures and classes. But there you have concentrically organized the bony lamellae called osteons, and they will be the histological unit of the bone, and that's a more compact bone. You don't have many wide spaces in contrast to the spongy bone, and that makes a big difference between those two kinds of bones. But you will learn more details on the microscopic structure of the bone in the histology. This is not part of the anatomy. If I go on, then the next slide goes to the long section of the femur again. And if you look at this structure, one at the first moment has the impression that this is just a randomly organized system of bony trabeculae. But when you look closer, it turns out that this system of bony lamellae is not just randomly made up by. They have a really smart and beautiful system, and one can define a more or less vertically running system of bony lamellae, which is called the so-called Paschen trajectories, because they withstand the compression. They will carry the weight of the body. And in the neck of the femur, for example, because the loading comes from above, it has also more or less perpendicular system of other trajectories as well, which is called the traction trajectories, and they will also carry the weight, and they will convey the force towards the compact part of the bone downwards to the lateral side. So this very beautiful system shows how the force is carried to the next part of the skeleton, and the internal structure of the bone mirrors also this kind of force. You don't have to think that this is a very rigid and a never-changing system. So if you change your lifestyle, if you start to do exercise, or if you change sports, kind of sports what you are doing, or you just buying a new pair of shoes for doing exercise, this lamellar system may be rearranged to the new mechanical requirements. So it's the bone is a continuously changing and adapting, very smart system, and it is not just a dead crystal-like tissue, but it's a very living and continuously adapting system. And this trajectorial system may adapt also to the new mechanical requirements by rearrangement. Earlier, I mentioned that I will explain what is this epiphyseal line here. And this is related to the process of the growth of the bone. And the epiphyseal cartilage is the place where the longitudinal growth of the bone takes place. So if you take an X-ray of your shoulder, most of you are under 24 years of age. And therefore, if I would take an X-ray of your shoulder, most likely I would get a similar picture now, that I would have the head of the bone, I would have the body of the bone, and at the border between them, I would have a cleft on the X-ray. And if we examine this closer, it turns out that this is a cleft filled by cartilage, and this is called, therefore, epiphyseal cartilage. And within this cartilage, the cell divisions of cartilage cell will take place, and this is how the bone gets elongated. This is the place where the longitudinal growth of the bone takes place. Importantly, with the age, this epiphyseal plate or epiphyseal cartilage will get smaller and smaller, and it is variable at what time, and it's also depending on the bone, but latest the proximal epiphyseal plate of the humerus closes, and after the ossification of this cartilage, the longitudinal growth of the bone is not possible anymore. Around 24 years of age, this ossification takes place, and after this, no more longitudinal growth of the bone is possible. Other bones ossify, other epiphyseal plates ossify earlier, but this is the last one which closes. And then the longitudinal growth of the body is then stopped. Okay, then the body height is of course also determined by the growth of the bones, and it is also important to keep in mind that the epiphyseal plates have a typical time when they close. So if we see a bone or somewhere a dead body is found, or just bones are found, based on the thickness, the width of the epiphyseal plate, the forensic medicine department or the specialist there can approximately determine the age of that person whose bone was found. So it has some forensic significance as well. Also, the development of the bone is important for your future practice eventually. These X-rays are coming from the hand or the root of the hand of people of different age. On the left top picture, you have a newborn hand, and then here you can see 1, 2, 12, and a young adult person. So if you compare the pictures, one can see that the bones in the root of the hand and also the carpal and metacarpal bones change their shape with the time. And you can see how the ossification centers appear here. So at the date of birth in newborns, all the bones of the root of the hand are still cartilages, and then step by step, gradually, the ossification takes place. Here you can see that ossification centers appear. Also, the ulna has here a small ossification center, the radius. So at what time these ossification centers appear has also a clinical significance. And with these kind of x-rays, you can determine the bone age of your patient. So you know the chronological age, that's easy. You know where the particular person was born, and you know that he or she is 1 or 2 or 3 years old. Now, if you have a patient who has, I don't know, problems with the body height, and the parents are coming to you that, well, we have this kid, she's, I don't know, 3 years old, and she's the smallest in the kindergarten, and then we don't know what's wrong with her or with him, then you may take an x-ray of the root of the hand, and it turns out that what is the bone age of that particular child. And you can compare this with the chronological age, and then you see if the development of the bone was normal or not. So this is sometimes required. That shows you one example for the medical importance of the ossification centers. At what time does a particular bone or part of a bone ossify, and at what time does the ossification center appear the first time. So this is something that also might be important if you study in future pediatry, for instance. Okay, this is what I wanted to tell you about the bones and parts of the bones in general. And then let's talk about the connections of bones now. And this is the so-called arthrology. Arthrology refers to the part of the anatomy which is about the bone connections. And bones may be connected with each other continuously. That means that there is no real gap between the bones, but there is some filling material between the two bones. And some books call these connections false joints, because there is no true gap between the bones, but you have some tissue that fills the gap between the bones. There is an intervening tissue between them. And we have 3 options here. One could be that we have a connective tissue connecting the bones. That's called syndesmosis. We also may have cartilage connecting the bones. That's called synchondrosis. And we also may have some bone that connects the bones. So basically the bones fuse with each other, ossify together, and that's the so-called synostosis. Let's have some examples for each. In this slide, I give some examples for the syndesmosis, which means that connective tissue fixes the bones to each other. I have here the skull bone, and there you can see parts of the skull where the bones are connected to each other. Sometimes this connection is quite wavy. Sometimes it's straight. And in some cases, you can see that the bones kind of overlap with each other, like the fish scales overlap with each other on the back of the fish. So these are different kinds of sutures of the skull bone, like the plain suture is here, which is straight. You may have the so-called squamous suture, which is like the fish scale. And finally, you have the serrate suture, which has this zigzag-like pattern. The bones are wedged into each other like the pieces of the puzzle game are connected to each other. So these are just examples for sutures. You will learn about these sutures in detail at the end of the semester when we talk about the skull bone, but sutures are examples for syndesmosis. Also, you will very soon learn about the 2 forearm bones, the ulna and the humerus, ulna and the radius, sorry. And you will see that the ulna and the radius are connected by a very strong connective tissue membrane called interosseous membrane of the forearm. And this is a kind of ligament that connects the 2 forearm bones with each other. It's also a strong connection between bones. Finally, another example which comes up in the next semester when we talk about the teeth. Teeth are sitting in the alveolar bone, and you can see very strong but very short connective tissue fibers which fix the tooth in the alveolar bone, and that is the so-called gomphosis, which is performed or made by the periodontal ligament. That is a structure which fixes the bone, fixes the tooth in the alveolar bone dentistry students will need this every day. We will come back to this point in the next semester. Okay, so these are examples for syndesmosis if two bones are connected by with each other by connective tissue. The next slide shows the second type of continuous bony connection if the filling material between the two bones is cartilage. That's why it's called synchondrosis. Chondros means cartilage in Greek, that's why the name. And some examples are the discs between the vertebrae, intervertebral discs are indicated here. Also, one can mention this piece of cartilage connecting the two pubic bones with each other. This is the so-called pubic symphysis. You will learn about this soon when it's about the pelvis. And also in some books you will find that this is not a true synchondrosis because in many people there is a narrow cleft within this cartilage, and this can be defined according to some ways of thinking as a kind of cavity of a joint. Therefore, it's a kind of transition between true joint and synchondrosis. So some books will define this as a hemidiarthrosis. So it's a fake diarthrosis. But if you say synchondrosis, it is also fine because this is just a different way of thinking about the same structure. So synchondrosis means cartilage fills the gap between two bones and the two bones are connected by cartilage tissue with each other. And the third option of continuous connections are the synostoses. That means that the bones ossify and they fuse together. The best example is probably the sacrum. This is a bone that is found in the pelvis, and if you look at this, you can see that it is made up by 5 vertebrae, which fuse with each other, and the fusion areas are also visible by these horizontal lines running here. These are the places where the borders of the vertebrae were before they have fused. And another example for synostosis could be the hip bone, because the hip bone ossifies from 3 different sources. You have the pubic bone, you have the iliac bone, and you have the ischial bone you are sitting on. And these 3 bones fuse with each other with around 18 years of age. And after this, one can talk about one single hip bone, but it's made up by 3 bone originally, which finally fused together. Okay, so these were just some examples for synostosis. Also, this bone is such a thing, the coccyx, but you will learn several more examples for that. But in general, now we are done with the continuous bony connections. I discussed with you the syndesmosis, the synchondrosis, and the synostosis. And let's turn now to the discontinuous bone connections, also called true joints. And before I tell you the classification of the true joints, what I have to do is that I tell you what parts does in general such a thing have. So what parts do true joints have? So these are called true joints because there's a true gap between the bones. Here is a bone, there is another bone, and there is a gap between them. So these kind of connections allow significantly more larger movements than the continuous bony connections we have finished, because they are quite fixed structures. Now, this is an organ, so joints are organs, and you will learn in anatomy that if we have an organ, they have always a border, they have always a wall, boundaries they have. So this joint is covered by a capsule that is the border of that, and it's called articular capsule. It has an inner layer which is called synovial layer or membrane, and outside you have a thicker connective tissue that has already a larger mechanical significance. That's the fibrous layer of the capsule. Then the bone has a surface which is covered by cartilage, and most of the times you have one which forms a socket, which has a concave shape, and usually we have also another one that has a more or less corresponding convex surface. It's called another articular surface. In many joints we will call them ball and socket, surfaces, or we call them male and female parts, depending on what book you use. And then we have a cavity between the bony or cartilage covered surfaces. This is the articular cavity, in which you find some fluid, articular fluid, synovial fluid also called, that is like an oil, which is there to cover the surfaces and to reduce the friction. It allows the movements because it makes the surfaces covered by this quite slippery material. And then the cartilage I mentioned already, the blue color, the light blue color, wants to represent the articular cartilage. It's most of the times made up by hyaline cartilage. In some cases, it's fibrous cartilage, but that's more rare. Okay, these are found in all joints, but we also have some other things which may be found in joints. And these are so-called optional constituents of joints. So not all the joints have those, but they have a great significance in that particular joint where we are talking about these structures. So this slide will summarize those optional constituents. First is the synovial bursa I have to mention. The synovial bursa is typically a structure that has a synovial membrane, and inside you have a fluid that will, similarly to the joint cavity, articular cavity, reduce the friction on the surfaces. And these structures are in the neighborhood of larger joints, where they allow the movement of tissues on bony surfaces. In this case, here is the patella, and in front of it you have the skin of the knee area, and you have to allow somehow that the skin can be shifted above the patellar bone. Therefore, we have this synovial bursa, which allows the movement of the skin in this case. In some cases, tendons will have synovial bursae, which allow the movement of the structure above bony surfaces. In many joints, we have synovial bursae. They have names, and they might be sometimes inflamed, and they might be sometimes very painful because if they are inflamed, they will then cause pain, and the patient can't move the joint properly if the bursa is inflamed. Ligaments are probably the most common optional constituents, and some books will say that the ligament is an obligatory part of the joint because almost all the joints have it. Indeed, that's true, but still not all the joints have a ligament, so some books will define this as a optional, others will discuss this as a obligatory part. It doesn't matter, we won't argue with you on this in the exam, but please note that the ligaments are important parts of the joints. They connect the bones with each other, they stabilize the joint, they restrict the movements, and they give a certain mechanical support for the joint, and they reinforce also the capsule. The meniscus is a rare optional constituent. It's found in humans in the knee joint. You will get classes about the knee joint. There are two menisci in the knee joint. They should fill the gap between the articulating surfaces if they are not fitting anatomically with each other. There is a so-called incongruence between the surfaces, which means that anatomically they don't really fit. Then there is a kind of piece of cartilage in between the articulating surfaces to equalize the anatomical difference between them. In some joints, we have articular lips. This is a part of the shoulder joint, and this is the glenoid labrum here, which deepens the socket of the shoulder joint in order to stabilize the joint. A similar one you will find in the hip joint also, and you will discuss the significance of that later, but briefly, it is there to deepen the articular surface and to enlarge it to stabilize the joint. In some cases, the articular surfaces are a little bit far away from each other and they don't fit anatomically. Therefore, there is a piece of cartilage in there, in between the surfaces, and it separates the joint cavity into two, and that is the articular disc, which is found, for instance, in the sternoclavicular joint. This is an example for that, but in other joints we have also a disc, like in the temporomandibular joint, that is in the mandible. Okay, and we also have so-called articular muscles. In some cases, articular muscles may reinforce the capsule of the joint, but sometimes it will move the capsule of the joint to avoid that the capsule of the joint is pinched between the articulating surfaces when you carry out a movement, because that would be very painful. So in some joints, we also have muscles which support the actions of the joint. Okay, so this is the list of optional constituents of joints. I gave some examples, and when you study in the class the joints one by one, you will get several examples for these, and always your teacher in the class, your professor, will refer back what group of or what kind of part of the joint is that. If it's an optional one or an obligatory one, you will classify them several times, but please keep this in mind. Okay, and now I go to the classification of the discontinuous bone connections. I told you that we have the continuous one, and those were the synchondrosis, syndesmosis, and synostosis. And now we come to the true joints, also called diarthrosis or synovial joints. And Latin books use the term articulatio. And these joints have a true gap. This is what I was talking about. What parts does a joint in general have? And now let's classify them. How to classify the joints is the question. So true joints may be classified according to the number of axes. How many axes do they have? Some books will use the term degrees of freedom, which means around how many axes is the movement allowed in a particular joint. And if we follow this classification, then one can define uniaxial joints, which have one axis. Biaxial joints have two axes. Multiaxial joints have many axes. Usually we define the three main axes of the body as the axis, but in fact they are multiaxial joints. And one can define a special subgroup of the diarthrosis, in which case the movement of the joint is practically impossible. It's very, very restricted. In this case, we may call them fixed, plain, or stiff joints, but with the medical term, they are designated as amphiarthrosis. Okay, so this is a specific type. This will be my last slide today. But before that, I will explain you and give examples for the uniaxial, biaxial, and multiaxial joints, because each of which has its own subgroups. For instance, if we go to the uniaxial joints, we will first meet or discuss the hinge joint. The hinge joint is a joint that has only one single axis. That's why uniaxial. And typically in this scheme, you can see that you have a socket, you have a cylindrical surface which fits with that, with a cylindrical concave surface, and around one axis you can carry out only the movement. You can do this when you move your fingers, you flex and extend your fingers, because the so-called interphalangeal joints are the best examples for that. But the humero-ulnar joint, that allows the movement of your elbow this way, or the talocrural joint is your upper ankle joint, is also a hinge joint, in which case you only have one pair of movements. Collateral ligaments you have typically in these joints. This is a common feature of the hinge joint. Also, if we stick to the uniaxial joints, the other type of the uniaxial joint is the pivot joint. This one is a joint that allows, again, a movement around one single axis, but that axis is typically parallel with the long axis of the particular bone, what you are talking about. And this example here shows you the atlantoaxial joint, which means that around this axis you can rotate your head. because the first cervical vertebra on which the skull is sitting is twisted around the tip of the second cervical vertebra, and the rotation of the head is allowed in this pivot joint, so-called atlantoaxial joint. We will talk about these joints in detail in your practical classes. We also have another example. The proximal and the distal radio-ulnar joint of the forearm allows this kind of rotation of your forearm. And you may combine these two joints with each other. This happens in the elbow joint because you may combine them. And this term refers to the type of the elbow joint. This is the so-called trochogynglimus joint, because the hinge is called in Greek gynglimus, and the pivot is called in Greek trochoid joint or trocho joint, and therefore it's the trochogynglimus, the combination of those two. You will find this later when you talk about the elbow joint in detail. These are some movement examples, because in this online situation, I cannot really demonstrate these movements. If I would stand in the lecture room, I could show you, but I made this slide that you understand me. So forearm pronation and supination, this is a kind of rotation along the long axis, and the rotation of the head is a pivot joint, and hinge joints are the elbow movement in the humeral-ulnar joint, and your upper ankle joint in the foot is done in the hinge joint also. These are typical uniaxial movements. We move to the biaxial joints. They have already two axes, which makes the story a little bit more complex already. So you have two axes because the surface is an ellipsoid surface, which fits more or less with a concave ellipsoid surface. And ellipsoids have two axes, so they are egg-shaped articulating surfaces. And if you imagine you have an egg in your hand, you have an egg which has a long and a shorter axis, and therefore one can carry out movements around these two axes. Examples could be the atlanto-occipital joint, which is again in the neck. You can move your head forward and laterally. This is such a thing. It's a biaxial joint, ellipsoid joint, so-called atlanto-occipital joint. We will talk about it in the classes later. The wrist joint is also a good example that you can move your head back and forth like the palmar and the dorsiflexion, and you have the radial and ulnar abduction, which is a combination of the two axes together. So in one joint, you have two direction of movements. That's why some authors say that we have 2 degrees of freedom, because we can move the joint in around two axes in 2 directions. Another example for the biaxial joint is the saddle joint. We only have one true saddle joint in the human body. In this case, two concave surfaces meet with each other, which have also convex curvature. And if you put them together, again, in 2 directions, the movement is allowed. Again, 2 degrees of freedom we have therefore. And the example for that is the carpometacarpal joint of the thumb, which is the joint that allows the movement of your thumb. And one can perform in this joint the abduction and the adduction when you move your thumb closer to your other fingers and you move it away. Or you may also move your thumb and turn it around that it can meet the other fingers. This is designated as the opposition. And if you move it back, that means the reposition. Okay, so you have again 2 pairs of movements because you have 2 axes, 2 degrees of freedom, and the saddle joint is another type of the biaxial joint. So this is not a common type of joint. Saddle joint, we have only one in the human body, but we have more ellipsoid joints. I also named 2 examples in the upper part of the slide. So these joints have 2 axes. And then we turn now to the multiaxial joints. These joints have many axes, but we usually define 3 only because we keep the main axis of the human body. So we have here the 3 degrees of freedom, but these joints can be moved practically in any directions. And if you take the shoulder joint as an example, you will see that you have a ball-like surface and it meets with a socket. And in this scheme, you can also see the same thing. So a round spheroid, almost complete sphere part meets with an excavated shallow socket that fits anatomically well with it. And therefore, we may call this also ball and socket joint, or also called spheroid joint. And because of the several allowed movements, directions, one may call this also free joint. So this is the shoulder joint. And in the shoulder joint, one may carry out the adduction, which is carried out around the sagittal axis. You may use the transverse axis, which goes through here. Then is the flexion and the extension if you move your shoulder forward and backward. And also, you can twist the humerus around its own long axis when you rotate your shoulder in and outwards. That is the medial rotation or the lateral rotation. These are 3 pairs of movements. That's why we talk about 3 degrees of freedom. And one can also combine these movements. So if you make a circle with your upper limb, you are combining all these movements at the same time, and you carry out a circumduction in your shoulder joint. So you draw a cone at this time with your upper limb. And the best example for that is the shoulder joint, but we have quite a lot ball and socket joints in the human body. But only rarely they are really free joints, because they are many times restricted because of some ligaments. They might be in some or multiple directions restricted, and they are not allowed to carry out unlimited movements. That's why they may be designated as restricted ball and socket joint. For instance, the sternoclavicular joint is such a joint that is between your clavicle and sternum. So if you lift your shoulder, you move it forward, backwards, you can do that, but the movement is not unlimited. Some ligaments will restrict the movements of the sternoclavicular joint. In the classes, you will learn what exact ligaments will stop the movement after certain angles. And it's also a specific type, the so-called anarthrosis, which means that in some cases the socket is deeper than the half of the head. So if the head of the joint or the bone is beyond the equator surrounded by the socket, that will definitely inhibit the movement, and of course it stabilizes the joint. And in humans, we have a cartilage lip around the acetabulum, which engulfs the head of the femur, and finally it will therefore defined as an anarthrosis. It's a specific type of the ball and socket joint. In humans, we do not really have a true bony anarthrosis, but with the cartilage lip of the acetabulum, the hip joint can be considered as an anarthrosis. So this is what I wanted to say about the multiaxial joints. And finally, because the time is almost over already, I have one single slide about the amphiarthrosis. This means that you have basically flat or irregular surfaces which fit more or less with each other, but if they are rough and they are flat, they won't allow you that big movements. You have a normal capsule, you have very strong ligaments, but they do not allow movements. Any movements or only very restricted movements are allowed. And I listed here some examples. The carpal bones are joined by amphiarthrosis with each other. These are called the so-called intercarpal joints, but then the metacarpal bones are connected to those by carpometacarpal joints again, except that of the tongue. The others are amphiarthrosis. The sacroiliac joint also is a fixed joint, and the bones in the root of the foot, tarsal joints, intertarsal joints, are also fixed joints. They don't allow any movement, but they have a true cavity, they have a capsule, they have ligaments, but they don't allow you movements or only very restricted ones. So this is what I could cover in 45 minutes, and this is the general osteology and arthrology. And with this, I would like to thank for your attention, and I wish you a nice day. Thank you.